our topic today is patient-centric rehabilitation. As I mentioned, my name is Jody Gutkin. I am a physical therapist. I am from the baccalaureate degree days, so I have been practicing for over 25 years and had the opportunity to work in a variety of practice settings. Acute care, inpatient, intensive care, general medical, total joint. I've followed patients through the continuum of care, working also in inpatient rehabilitation, neuro rehab. I was a physical therapy supervisor at a teaching hospital and saw patients with head injuries, spinal cord injuries, amputations. Moving down to Florida, I expanded my practice to include the skilled nursing setting. I've also worked in adult and pediatric home care environments up in New York and down here in Florida. And with pediatrics, I've seen the continuum of care from the neonatal intensive care unit through outpatient rehab and working in the school system also. In my next life, because I do love therapy so much, I have worked in outpatient rehab also and went on to complete my master's in education. And I have been also working in a physical therapy program as an educator for many years. So my master's degree is in online teaching and learning, which lends itself to this environment. And actually many of the things that I learned about building rapport and interactions with students translates well into therapy also. So I look forward to sharing some of my stories with you as we go through today's topic. Our purpose today is to look at our interactions with patients and what goes into our communication and patient satisfaction and some of those factors that go into having positive outcomes for our patients that aren't necessarily related just to our intervention selection or our hands-on technique. And that's a little bit of an uncomfortable thing for us to look at sometimes. We don't necessarily want to have to look at how we're coming across or how are we interpreted. Oftentimes individuals feel like they're being told to act a certain way or speak a certain way, which actually is not the case. Our goal today is to look at what the research says about our relationships with patients and how it impacts ultimately our rehabilitation and our outcomes. So it's kind of a little bit different course. It's definitely lighter in terms of content and a little more introspective. So I hope you enjoy this different perspective on things. Our goals, what we're going to specifically take a look at are going to be from the patient's perspective. What are they looking for from therapy? What are their expectations and goals? Then how do we bond with patients and build a productive therapeutic relationship? And then finally, we'll take a look at some of our intrinsic qualities and communication style and how does that play into the message that we're delivering and how well it is or is not received. Everything that we talk about today, as with any course that you attend, you're going to apply in the clinic in accordance with the federal, state, and professional regulations wherever you practice. So just follow that when you get back into the clinic tomorrow. And if you notice on the bottom right-hand side of the screen, get my marker here. There we go. So on the bottom right-hand side of the screen here, there's a little icon that's blue and it says consider this. You'll see that on several slides throughout the presentation we have that icon, and that's to let you know that those particular slides are going to be helpful when you go to complete the post-test later on. So they hold information that'll help you answer those post-test questions. But don't worry about passing the post-test. You most definitely will get at least that 70% or higher. So we're discussing patient-centric rehabilitation. and our interactions with our patients that go beyond just the performance of our interventions. And what we first learn when we're in school, right, is how this thought process emerges of taking a patient from diagnosis through interventions to achieve their particular goals. And historically, the Nagy model is what we learned that has us very linear thinking. And this is what I learned back in school, taking a look at the patient has a pathology. What impairments does that result in? What functional limitations do they have? And then how does that provide a social restriction for them? So it has us consider that patient who, let's say, has an ankle sprain. Their impairments are they have swelling, edema in the ankle, restricted range of motion, and pain. Because of that, they are unable to walk. And because of that, they're unable to go up and down the stairs at their job, so they're unable to work. How do we come in there? We fix the impairments, we improve function, magic, patient should be better. And generally speaking, those are some things we need to consider. However, the World Health Organization in 2001 looked at this model and said, while yes, we do need to consider the impairments and functional limitations, that the patient is not in this little bubble that we treat, that they are interacting and they have social responsibilities, they have family obligations. They may or may not have the money to pay for that ankle brace, or if they can't be working, they can't put food on the table. So now if they're also diabetic, their diet is changed and that may impact their healing. So the World Health Organization put out the International Classification of Functioning Disability and Health to start clinicians thinking that we need to consider our patients more holistically, that there are other factors that come into play that influence their healing and their recovery. And we do that in therapy. We consider implications for our patients. When we look at our outcomes, though, for ourselves, in order to get that patient to functional recovery, we can't just spend all day with them, right? Well, I started practicing many moons ago where you could if you wanted to, but now you can't. We have more, stringent restrictions on us that we're looking at. Yes, our treatments need to be effective. We also need to be efficient in our time. We have X number of visits to rehabilitate the patient. We have to be productive during our hours, that we have to show that our time is all accounted for. And we also need our patients to be happy. So the focus is that we need to, let's say, decrease that patient's pain, increase their range of motion and function, but did we accomplish that before their funding ran out? Were we productive enough that we saw as many other patients as we needed to in that same day? And also, was that patient ultimately happy with how that all went? And then, right, rinse and repeat that 10, 15, 18 times a day, every day. There's a lot of factors that we need to consider, a lot of perspectives. And when we're looking at that, things that contribute to us in our ability to accomplish those different goals is to make sure that we are picking interventions that are appropriate, that we specifically have the technical skills to execute them. And then we need the patient to play a role, right? We give them a home program, that those couple hours a day that we're seeing them in therapy, or if you're in a skilled or a rehab setting, those several hours. There is still carryover activities that we need from them to buy into so that this whole package comes together. Even if we do that, right, you can all picture patients that you've worked with. I worked on an orthopedic floor with total joint replacements and in outpatient. You could have patients with that same total knee replacement, that past medical history is the same, yet you do the same interventions with both of them, and the outcomes are completely different. Even if you account for the fact that maybe one of the patients also has congestive heart failure or emphysema, so you're adapting your training for them because of the medical piece of it. Still, we have variability in our patients becoming functional. Are they happy with where the treatment ends up? So there must be some other variable that's coming into play. And one thing that the research is saying we need to consider now is our definition of recovery. how do we define that ultimate function that the patient has? That whole perspective of recovery for us to develop our goals, that target that we have. Where do we get that from? And what the research is saying is that there's a difference between a patient's ideal versus expected recovery. That this whole concept of ideal versus expected, we need to tune into when we're interviewing our patients, and we need to be aware of. Here's the difference. Ideal recovery is what they hope, what they desire, what they would prefer. The expected is realistic what they think is going to happen. And here's an example from very early on in my career. I still remember this particular patient who had a transfemoral amputation. And I was excited. My first patient I was going to, teach how to use a prosthetic device. And it was so, so exciting for me. So I, did the evaluation, and I'm talking about the prosthesis and getting her ambulatory because I saw her total potential with that. I wasn't getting the same excitement back. Couldn't quite figure out why. So over time, it did take me a couple of sessions in working with the patient to find out that, kick myself now for not catching this sooner, but I did end up catching it for a positive outcome, that, you know what, ideally, yes, she would love to be ambulatory on that prosthesis and independent. However, she and her husband, who is older, also has his own medical compromise, that they loved going for walks along the boardwalk every day. That was their time together, and their whole day kind of revolved around that time together. They've always done it. Well, now, if she's ambulating up on her prosthesis, sure, she would love to be able to do that, but she just doesn't have, because of her medical complications, because of her husband being the one that needs to assist her, it wasn't going to allow her to be ambulatory to go the distances that they go for that piece of their life that was so important. So her goal, so ideally, yes, that's where she wanted to get to. Her expectation, though, her reality was that's just not going to happen because of all the other pieces that go into it. And at the time, paying for the prosthesis on top of it. So her expectation was, I want to be independent completely at the wheelchair level. I want to have the endurance to help propel that wheelchair myself so my husband and I can continue to take those long walks together, even though she is wheeling. So we modified our treatment program. I did a lot of, decubitus management, skincare, positioning, endurance training for wheelchair propulsion, incorporating standing activities, ambulatory without the prosthesis, short distances to prevent the osteoporosis, contracture management, all those things. And you know what? That patient was so happy, and I think of her today, that I was able to meet her goals. But the only way I was able to do that is because I was able to tap into what she wanted. Had I kept pushing her to be independent ambulator on a prosthesis, it probably wouldn't have been a positive outcome for anyone. sometimes we need to take a step back and really look at, well, what is this expectation of recovery? And for a patient, it's for anyone, the belief that some future event's going to happen. If this, then that. And where do they get that from? How do patients come up with it? Well, the research is starting to show that there's a very clear way patients determine what their expectations of rehab are and rehab outcomes. In 2016, there was a study. It was a small cohort, but they looked at patients with musculoskeletal pathology, and they asked them to rank and describe how they decided what their outcomes would be in therapy. And for many of them, it was related to the experience of others. That information, suggestions that they get from other people played a significant role. Another piece that came into play was this idea of self-efficacy. And self-efficacy is an interesting thing. And this gets into the idea of, if you will it, can it happen? But to explain it a little more specifically, if you go to the grocery store and you forgot your grocery list, you realize when you're in the parking lot, do you turn around and go home because you don't have your list, you don't know what you need? Or do you sit there for a minute and think, okay, Monday we need breakfast, lunch, and dinner. What do I have? What do I need? Do you figure out a way to make it work? Self-efficacy is that sense in yourself that, you know what, I'm going to accomplish this task. I'm going to figure out a way to do it and make it happen. For some people, that's stronger than it is in others. And for some patients, that plays a role in their rehabilitation. Does expecting they have what it takes to get through rehab and have a positive outcome ultimately play a role in their achievement? And the research, again, is looking at this kind of nebulous factor and trying to explain it a little more concretely. So in evaluating patients and doing some research in those that had whiplash, low back pain, and shoulder pain that was related to a work-related injury, they studied individuals who went to a workers' comp physician that they were obligated to go to versus those who went to a physician that was referred by a friend. And they found that those that went to someone referred by a friend had better outcomes because they felt they were getting better care. It didn't matter the training of the physician or other factors. It was just their perception somehow made a difference. They also took a look at surgical patients. Now, surgery, right? If the surgery goes well and there is no complication, we would expect a similar outcome. So they looked at total joint replacement patients who had a low concern going into surgery about complications, that they expected to have pain relief from their orthopedic surgery, right? The osteoporotic bone is removed, new joint in place, they should have a healing pain and then less pain. They actually found that those patients that went in with those better expectations functionally after surgery had higher function achievement. They had decreased postoperative pain. So the data is really starting to support that this makes a difference. How do we get our patients to align their expectations then? We need to accomplish this somehow. In our initial conversations with the patients, we need to look at the fact that we have to address any misconceptions that they have, what is and is not possible, and then trying to, negotiate that. We also want to let patients have mini expectations. That's definitely helpful for them. So let's say your patient comes in and, they had male patient, have, a little 5 o'clock shadow. It's getting to be more than 5 o'clock as the sessions go on. And maybe they, casually mentioned, oh, this, beard growing in, I have to let it happen. Or you comment on it and they're kind of a little negative about having it there. Maybe you steer the conversation towards, well, what made you decide to grow it out? And if they're saying, I can't stand at the sink to shave because of my hip pain, back pain, or upper extremity pathology, whatever it may be, well, how about you make a small goal for that patient? Instead of that patient's goals being, increase hip flexion range of motion to, 100 degrees and increase, shoulder range of motion and strength to X values, maybe for that patient you say, well, how about we make our goal for the next 2 weeks to get you to be able to stand for 15 minutes, increase your standing tolerance, so that you can get to the point of being able to shave, and then your rehab interventions go around that. Do you think that's achievable? Now you're negotiating with the patients that they're playing a role in making that decision. And then also what you give them for their home program will relate back to that. So you're going to negotiate that patient's role in recovery. You're going to get buy-in from them to hopefully increase their compliance. There was a study of 2,000 participants in Canada, individuals who sustained, I think it was a whiplash injury, and they worked at computer stations. So they looked at those, again, who expected to return to work after their injury versus those who were like, yay, I'm out of here. And they found that those who had an expectation to return to work, that their rehabilitation progressed 42% faster than the others. So this is definitely playing a role. Aligning those expectations make a significant difference for our patients. That we want to consider, looking at what do they think versus what do they want to occur, what do they need. And again, negotiating that, referencing specific functional tasks for our patients. Pain, we use pain as a goal. Patients come because they're in pain and they want that pain to be diminished. Well, how do you know what number to put in your eval as your goal? Pain 0 out of 10, is that your standard for every patient? And I'm not saying it's wrong, I'm just kind of throwing out something out there to consider. Have you asked your patient what would be an acceptable pain level for you in 4 weeks? Because maybe for that patient, and what would be acceptable function? Because maybe for the patient, you know what, if I still have a 3 out of 5 pain, but I can get in and out of the car on my own so I can get back to my volunteering job or go pick my kids up at school, maybe that's acceptable for them. That's your short-term goal. Or does that patient want to be able to go back to playing tennis as their functional goal? So looking at taking that extra moment to get the patient's perspective. Same thing when we're selecting interventions. To get that patient buy-in a little bit more, as I mentioned, the research is saying what friends experience does seem to play a role in what patients think is going to be beneficial. So if you have a choice, you're trying to gain, let's say, that hip flexion range of motion on the patient, and you can either do active assisted heel slides, or you can put that patient on the bike, adjust the seat height for the range that you need, their balance is okay, they can tolerate it, and they're, pedaling to do their range of motion. If it truly, those are like equal footing based on that patient, and you're like, I don't know, which one should I do? Why not ask the patient? Because one patient may say, you know what, I would rather be on the bike because my cousin John was on the bike and I hear from him every weekend when we have dinner together, oh, well, I was already on the bike and you're not. Oh, you mustn't be doing well. That patient may want to be on the bike. Whereas another patient, you put them on the bike and they're thinking, you don't care about me. You're sticking me over here so that you can go work with someone else. Maybe that patient needs the active assisted heel slide. I don't know. Consider asking them. And it may, again, have an impact that's positive for all of us. Because there's something to be said, and again, the research is showing it, for placebo. I am not advocating deception. I'm going to tell you what the research is showing, and then you think how this comes into play. We're still going to do interventions that have specific outcomes, but placebo studies really help us understand that where patients are coming from and the cognitive piece plays a role. So they took individuals and they induced ischemic pain for them. So they performed rectal distension with fluid and they injected the patients. The control group did not receive any lidocaine injection. The treatment group received lidocaine injection. What they found is they gave each group the same different instructions. So they gave the group that received the placebo. They did not receive any lidocaine, and they clearly are experiencing pain from this intervention. So the patients that did not receive lidocaine, those were told as they got the injection, this intervention significantly reduces pain in some patients. Set up a positive expectation. The group that did not receive any lidocaine, sorry, I spoke backwards. So the group that did not receive lidocaine, they were told positive expectation. This intervention significantly reduces pain. The group that did receive the lidocaine, they kind of set up a negative expectation. They said, well, 50% of this people, this may work, may not. Do you know that those patients who received the placebo had less pain reported than those who actually received the lidocaine? That just that mental expectation that was set up changed the patient's perception and had an impact for them. So how we deliver our message does seem to come into play. Those of us in Florida, you may have heard the news over the past several years, or the commercials, I should say, that are out there. They were trying to legalize medical marijuana. First time it went up for vote, the publications were, come on, we need you to vote. Here's the reasons you should vote yes. Here's why you should vote yes. When it failed, the marketing changed. Now the marketing, the second time around, was it barely failed. So the first time was, we need you, come on, join us. The second time was, it barely failed. Everybody else said yes, but you said no. We're already leaning this way. Why don't you just come on over? The rest of us are here. And it passed. Who knows if it was the marketing, but it kind of shows how presentation and things does play a role. Not to say we don't count, because we do. That as clinicians, our skills are very important. And when we consider someone who is very proficient at their job or an expert clinician, we all tend to think quality of care. We're not necessarily thinking personality-wise or delivery-wise, right? When we think of that clinician, that novice versus master clinician, what do you think of? That they apply current evidence, that they use critical thinking. Maybe they've been practicing for a really long time. Right? So those are the things that we tend to think of as someone who possesses the traits that is really skilled and should have really good outcomes. Some additional characteristics that multiple research studies have looked at. They've done interviews across many different disciplines, and they did not find that it was years of experience that made a difference. That is not what necessarily made someone the strongest clinician. It does play a role. However, they found that individuals who were determined to be more of an expert or better at patient care, that another factor that came into play is that, yes, they possessed a drive for lifelong learning, but they were really good at self-assessing themselves and delegating. For example, I've been practicing, like I said, I've practiced pretty much in every practice setting. And I will tell you, I've worked in orthopedics. I still do pro bono orthopedics, and I can achieve my patient outcomes. But if I get a complicated back patient, I am the first person to say after the evaluation, you know what? I'm going to refer you to this colleague of mine. I'm going to tell them everything we talked about, and I'm doing it for you because I really think that they have this particular technique down, or this skill that is what I think you need. I tell my family, I said, if you unfortunately have a stroke or an amputation, I am there, and yes, call me first. But for some things, I'm not. And I think, and the research is saying that individuals who have a certain awareness, and as we practice longer, we feel more comfortable with those differences and recognizing when to refer out. Also, what they found that kind of goes with this is that you empower your patients more. So individuals that were termed experts, which is not really the best terminology, but who were more highly regarded, had better outcomes. What they found is they tended to empower their patients more. That there was one study that looked at occupational therapists, and they gave them an evaluation, and they had to complete the evaluation, look at the evaluation that was completed, meet the patient, come up with a treatment plan, and execute it. Well, what they found is those that had more skill and better outcomes, when they went back and they had them take that evaluation and kind of tease out what pieces of information they used to come up with their plan, they found that the ones who pulled out more information that was related to the patient's life circumstances, that were more patient education focused, when they looked at their goals, more function and cue type oriented, that those were the ones who were more effective, that they had better positive outcomes. So this piece of patient empowerment and having them be part of the process is really something beneficial to our outcomes and proficiency as clinicians. This piece of having the patient be an active participant in therapy is important to note, because sometimes for us it's not time efficient, right? It takes a little longer to get our patients to if we have them participate, but it can be beneficial. We have to think that they have a lot to contribute, a lot to offer. Here's one example. I had a patient I was treating in home care for a total hip replacement, and her manual muscle test, and range of motion for hip abduction was significantly limited. She was a 2- out of 5 on her involved side, and her good, strong side, which needed a hip also at the same time but didn't get it, maybe was a 3, not even. So she tells me she's having difficulty getting into the shower. So we head over to the shower. It's a stall shower. There's a counter and then the stall shower here. And in my mind, I'm thinking, okay, 3 on her good side. So as soon as she lifts up that involved leg to step, she's going to Trendelenburg, and I know she doesn't have the strength to abduct, to step sideways into that shower. How am I getting her in there? So, I'm brainstorming all these things. I'm like, well, if I get a shower chair with wheels and a lock, then she could sit down on it and then be spun around to get into the shower. And we're standing in the shower because she couldn't get over the threshold. I'm trying to think, well, what if we have you step over this way? And it just, kind of outlined problem solving with the patient. And she's like, well, why can't I just stand sideways and step in? Now, in my head, objective information told me there is no way that is happening. But at this point, I was at a loss. Had my gait belt, I'm guarding, shower's dry, I'm ready. Chair nearby. Do you know she stepped into that shower? She lifted that leg up, stepped over, and she's like, I told you this would work. I was like, yes, it worked. So you know what I did? I took the victory. We went back over to the bed, and I said, you know that same movement you just did to step into the shower? Well, when we're doing our exercise, sliding your leg out to the side, I want you to use that same muscle. See, you can do it. And remember, you're having difficulty lifting that leg out of bed? Guess what? It's the same muscle you just used. She's like, oh, yeah, I guess it is. So take those moments. The patient does have a lot that they can contribute. So demonstrating that commitment and caring and getting the patient to buy in really does help and make a difference. That is the piece that the research is saying comes into play, that we need to be aware of, that we need to consider beyond that kind of linear thinking to develop our interventions, that our patients have a particular piece that they can bring into it. And over time, this has grown. This patient-centered care has emerged over time. And if we look back at the different decades, we've had a shift from I'm doing therapy to you or for you to, what do we say? I am going to help you transfer from the bed to the wheelchair. I am going to do this with you. So our perspective has changed to be more patient focused. And currently what this is called, the terminology for this kind of old concept, new name, is called the Therapeutic Alliance. And it's been called many different things. But the Therapeutic Alliance is kind of more of this partnership with our patient. And in that partnership, there are many pieces. It's not just getting them to buy in. It does have a piece of who we are as clinicians, and how we come across to them does play a role. It is an important piece of this. We're not trying to change you. We're not trying to make anyone the same, but the research is saying that it does come into play, all these pieces coming together. And this therapeutic alliance is a combination of agreement on our goals, a collaborative relationship, and then that affective bond that we have with our patients. This philosophy actually emerged in psychology, and it's translated over into rehabilitation as having all of these very influential factors for our positive outcomes. The agreement on goals we've talked about already. It's the fact that we want the patient to buy in. We want them to be stakeholders in the goal because it's for them, right? Ultimately, it's their life that we're trying to improve the function of. Think of that patient that comes in the clinic, and first thing, or if you're in acute care, wherever you may be, skilled nursing, and they're like, 5, 8 today. And other people are like, what? Bystanders, they're telling you their pain rating. That patient is telling you pain is very important to them. So that should give you a direction to go in, and that should help you determine your goals. The patient that you ask the pain scale, and we can all think of them, and we're trying not to lead, right? We're trying to not involve. Well, and how's your shoulder feeling today? Okay. All right. Well, do you have any discomfort? Because we don't want to plant the seed of pain. Do you have any feelings in it, discomfort, anything bothering you? Yeah, I guess it hurts. Okay, what's your pain rating? 0 being no pain, 10 being severe. They can't give you a number. That patient is not being difficult. That patient is unbeknownst to them, they are telling you pain is not the major issue for them. Your goals better not just be increase shoulder flexion to 180 degrees, increase strength to 5 out of 5, decrease pain to 0 out of 10. You missed the boat on that patient. Maybe think function for that patient. Anything they're having difficulty doing, pain is not their gauge. So think of these things to help get agreement ultimately on what the goals are for that patient. the collaborative relationship that you're going to build by engaging the patient in the conversation, by using them as that resource, like the ICF model says, is going to contribute in a positive way to your interactions. That the interplay of our clinical reasoning with what they're experiencing all those hours they're not with us is going to make you more productive and meet the needs of that patient. A patient I was working with who had an adductor strain. So we're doing muscle energy techniques. It was from working out. She injured herself. So our goal was to get her back to exercising and running. So we're, doing all your typical orthopedic type interventions and modalities and things of that nature. So we would be progressing, and in my mind, things were moving along the course, phases of healing and interventions where she should have been able to, start on the bike and then work back to walking and running. However, she just really wasn't progressing as I expected in her pain. She would continue to have, I want to say she would continue to have episodes. It was more that we were not progressing. We were kind of just stuck in the same holding pattern with her pain levels, her range of motion, her ability to tolerate, the pain interference type of things. And it would seem that on Mondays, we would make really good progress. And Wednesday, she would be kind of the same as Monday, but not that great. And then by Friday, we had almost backtracked and we were stuck. So finally, I'm like, and this didn't go on very long. It only went on like about a week and a half before I realized that, I'm missing something here. And I'm admitting I'm missing something. So I'm talking to her, so what's different? Because in my mind, she's hopping on that treadmill and running and not telling me. Somehow the patient's being non-compliant, maybe. But personality-wise, that wasn't it. I really did believe her. So anyway, shorten the story up, we went through things and we kept talking about, I'm like, well, what else is different? Tell me, what do you do during your day? Maybe she's sitting in the car with that leg jacked up or something's going on and she's straining it again. Turns out she works in an office and she's a petite woman. So I said, oh, so tell me about your desk setup. I'm a certified ergonomic assessment specialist also. So tell me, adductor strain, why am I looking at head position at the computer? I don't know, it had to be something. I'm looking. Turns out that she's petite. Her office setup didn't work for her. And she would sit, right? She'd get that leg up underneath her, kind of in that L, and be sitting on it to look at her computer screen, which was too high. So think of the adductors there trying to stabilize her as she is moving around all day, sitting there for hours, finally getting up for lunch just for a little bit, so that would exacerbate over the course of the week. That patient didn't need another massage or another technique or a kinesiotaping or whatever. She needed an ergonomic assessment, and that's what we did. So we were able to move forward with that. So sometimes this collaborative relationship is the piece that you need to get something from the patient and then she was happy. She helped me figure it out too. And we were able to modify things and move forward. And then I also had her buy-in for changing her office setup. Because, once we moved all the pictures and little knickknacks and things like that out of the way, we could get the computer screen in the right place to help her leg. So just some stories to make you think about that there are lots that our patients can contribute, lots of pieces of information, and different ways sometimes to look at the situations that can allow us to get to our goals. So that brings us to the conclusion of our first hour of the course, looking at patient expectations and how to start building our collaborative relationship and why it's important up here. So we were talking about the components of the therapeutic alliance, and they are the collaborative relationship, the agreement on goals, and the third piece that we are going to look at, which is the affective bond. So the affective bonds, looking at this piece, I'll pose this question to you. If you go to an expensive restaurant and it is known for fabulous food, if you have a bad waiter, does it ruin the meal? Can a bad waiter ruin your meal? It's a good question, right? And many people would say, yes, it can. You know, sometimes you ever go to some place when it first opens and you didn't like it because they're still working the kinks out. Didn't matter how great the food was. You go back a couple months later when the service is better and things like that, and suddenly you like it. You know, there's something to be said even in our personal lives that subjective piece plays a role, that how we feel, how connected we feel, or how much attention we're receiving does make a difference. So looking at our therapy, this has an important role, that there is an influence on outcomes, that piece that is missing, or that we're focusing more now on developing, that therapist-client relationship is really being recognized as having a significant impact on outcomes. When they've done multiple different studies looking at this, they found that strong therapeutic alliance, that patient feeling like we care about them, that they're a part of things, that there actually is better adherence to therapy, higher patient satisfaction ratings, and then actually decreased symptoms and improvements in function. And multiple different studies have looked at this. The question then becomes, if we each individually are buying in and developing this, what happens when you practice in a setting when you're not the only person seeing that patient? What happens when you have a larger treatment team? So let's say you're working in home care. So as the PT or the OT, we go in and do the evaluation, and then the assistant is seeing that patient. We don't see them again. So whatever bond we developed, can it be continued? Or can we, do it back and forth? If you're on a PT/PTA team in a rehab center or a skilled facility or an OT CODA team, what if you're in a large facility? Here's a little vignette. Imagine a patient who's in a large medical center. So a patient who's a 30-year-old male, sustained a T1 spinal cord injury, 2-month stay in the facility. So he's participating in hours of therapy a day, individual, group, co-treatments. Every discipline is involved in his care. Think about how many clinicians that individual is encountering. They did a study, and this is a little synopsis of a sample patient from this 2012 study. They looked at 1,400 patients who were at the Rehab Institute of Chicago and Mount Sinai Medical Center, which are really well known for the care for this population. And in that 2-month stay, the average patient saw 40 clinicians, 40 medical professionals, 17 different PT and OT clinicians, 222 treatments. Imagine trying to maintain a collaborative relationship and agreement on goals, unrealistic, realistic, looking towards the future for this, population that has a lot to consider. They actually found that they were able to maintain the therapeutic relationship that the patients did not have low patient satisfaction ratings. So there is an opportunity that there are ways that we can communicate among each other, and that if we all kind of follow the same philosophy of things, that we are able, even with medically complex patients, to maintain this therapeutic bond. Another population to consider that this is extra important with are chronic pain patients, right? They tend to feel that they're bounced around a lot, that we somehow need to get their buy-in in order to have improvement. And in 2016, the Journal of Compassionate Care, they did a systematic review of many different studies, and they found 5 studies to ultimately analyze, ultimately around 1,000 participants. And they said, well, okay, could culture be a role? So they pulled studies from Germany, United States, Australia, Canada. Most of the patients were chronic pain patients with low back pain, and they looked at the therapeutic relationship, and they really found a positive correlation and a strong positive benefit to those who recognized a connection with their therapists. Those patients showed decreased pain severity and decreased pain interference. So even if they still had pain, it wasn't stopping them from functioning. So we took it a step further and they looked at a study, and this is not the cynic in me, it's the research for all of your benefit saying, well, yeah, okay, so let's try to objectify this because that's still a little subjective. Do you know on many of the patients, they completed functional capacity evaluations in some of the studies to objectify their function? The patient's self-report of pain interference was less than the actual functional capacity evaluation outcomes. So things they could not do on the functional capacity evaluation in their daily life, they're saying they're able to do. They're able to get through that pain. So the variable that they were attributing it to is this focus or this piece of, the therapeutic alliance. That somehow this motivational perspective for these chronic pain patients, it altered their self-regulatory process and it allowed them to have less disability. Something curious to consider. When you look at the fear avoidance model of pain, and this is really oversimplifying it, someone has an injury, they experience pain, and they recognize that they're going to have pain for their injury. This is what I do to manage it. They confront it, and they move towards recovery. So we look at our right side here. That's the loop. Well, what happens sometimes is patients, they experience the pain, they have what we call pain catastrophizing. So for whatever reason, they're afraid of the implications of the pain. They're afraid of the long-term consequences. Maybe it's altering their life significantly, so it is causing other anxiety and issues for them. So what happens is they become afraid to move. Well, when they're afraid to move, we know physiologically there are changes in our tissues. There's fibrosis, there's shortening, maybe there's pooling of edema, maybe there's respiratory and cardiovascular compromise that ensues. So they're not moving because they fear pain, right? Well, what happens is anytime they do go to move, they're hypervigilant, they're more cautious, and you know what? They may actually have more pain because now they have other complications. So it's kind of a self-fulfilling prophecy in a way that leads them back. So it doesn't allow them to attenuate their expectations to the actual pain. So somehow we need to break into this cycle for those patients. Individuals who have that high fear-related avoidance of pain, they're going to anticipate pain with participation, so it becomes like a predicted pattern and almost like their beliefs are what's leading to that pain. So we need to somehow minimize that fear of pain. And research is looking at, okay, physiologically there are interventions and treatments we can do, but also what is that psychological piece that comes into play? And there are many different levels and ways and so many different studies out there looking at it. I'm just going to highlight a couple that have come up because let's say back pain, for example, we know that there's, a pathoanatomical origin, biomechanical contributing factors, psychosocial factors, cognitive, expectations of pain. All this comes in together. So they did some very interesting studies. And one of them that I'm going to mention, looking at this brain level kind of response, is they applied a placebo cream to patients. And then some patients actually received cream with a lidocaine in it. And then they used a gentle heat shock to that region. And when they looked at it, they found, and again, the instructions were that this is going to help relieve your pain. This cream should work. They found that even the patients who received the placebo, when they looked at the functional MRI, that there was altered pain activity in our thalamus that is going to interpret and regulate that and disperse the commands to the rest of the brain for reaction. So they found that there was a positive reaction to this placebo piece of it. Another example, looking at opioid bonding, they're finding that whether an individual is expecting that pain is going to be relieved or whether they actually receive a treatment or intervention that relieves it, that on PET scans, they're seeing opioid binding in that limbic region to ultimately relieve pain, even if they received a placebo. So again, not advocating deception. They were using these studies more of a way of saying how we present things, how we come across does have an impact, and that whole piece of expectation. Again, in an effort of research, I said, okay, well, if that's true, then the opposite should be true. That if the individual doesn't expect it to help, it shouldn't. But physiologically, they're saying, it's the brain's interpretation and reaction. So looking at this cognitive control piece, I found some studies where they looked at individuals who had Alzheimer's disease. Alzheimer's disease, one of the manifestations is it is going to target that prefrontal cognitive region. So there's going to be challenges in those individuals from a cognitive perspective. So theoretically, we should see less of a placebo response because they're not able to encode that cognitive memory of pain relief and the placebo and the association, that kind of complex thinking. And do you know that in that population, they saw less of a placebo response, feeding into this thought that it does play a role. So how do we modify these patients' expectations? We need to kind of reconceptualize things for them. We need to help them consider the impact and get their buy-in, increase their self-efficacy that what we're doing and what we're asking them to do is actually going to help and they are capable of it. And there are many different ways to educate patients. Everyone doesn't have the same perspective. All of you listening today don't have the same perspective. So there's two kind of big schools of thought out there on how we educate our patients. Biomedical model is what I want to say grew up with when I went to school, right? There is a physiologic cause. If I fix that physiologic cause, all better, okay? That there's an anatomical reason and we educate the patient on that and that makes a difference, which from that is true. However, the research now is saying there's this other piece, that this biopsychosocial model is where we need to consider. That there's this other piece, Waddle is saying, that you need to consider the context that the patient is in, their attitudes, their distress that they may have, family, economic factors, all these different things are going to come into play. And they've looked at educating patients in two different ways, and some of it has to do with what that patient is going to respond better to. So I would say try to get a read on your patient. Are you pulling out those anatomy models and showing them, the faulty mechanics for their back as they're bending and the compression on the disc in the intervertebral foramen of the nerve root coming out? Which is what we used to do. I mean, that I remember in school, part of my patient education was pulling out the model and showing it to the patients. That doesn't work for everybody. They're looking at that and some are like, oh, that's what it looks like. I don't want to see that. Versus the patient where you're like, you know what, I understand you can't get into that work truck because of the back pain. Well, you know what? The position you're standing in and tilting your pelvis let's simulate that. Let's replicate it. See how that causes you pain? Well, you know what? If you tighten up your internal girdle and you stand up erect, now let's try this simulation little environment that I made, because that's going to get you back to work, which I know you mentioned you need to keep those health benefits for your family. I totally get that. So let's work on making it easier for you to get back in and out of the truck for your shift. That may make a difference for that patient. So different things to consider. Same thing when we're picking interventions. I've mentioned previously that their idea of what may or may not work or shouldn't work is going to come into play. So if you have a choice of doing active versus passive interventions, see if the patient has a preference. And if it doesn't make a difference for you, if something's not contraindicated, consider that. The value of this therapeutic alliance was analyzed related to just that factor. That, modalities, back it used to be hum therapy. Those of you that were practicing, a lot of clinicians, there's documentation would be S, patient without complaint. O, hum, hot pack, ultrasound, massage to the low back. A, tolerated treatment well. P, continue. And you would see that in charts. I was the chart auditor for compliance at one of my jobs. I would see that session after session after session. Really? Like, what are we doing there? We don't document like that anymore because that's not holistic care. That's not pulling together all of our clinical reasoning, never mind this therapeutic alliance piece. But modalities came into question. That should you use and shouldn't you use them? Again, that's a whole other class. But there was a study that I found related to what we're talking about today, where they took 100 patients who had low back pain. And they looked at pain intensity, disability. They had to at least have a pain of 3 out of 10 on the pain scale for 3 months. So they were moving into more of a chronic pain. And what they did was the patients received a combination of different interventions. So some of them received a sham interferential current to their low back. So they didn't actually receive simulation. And they were given the instructions, maybe a 5-minute verbal, yes, this is supposed to help your pain. I'll be back in 15 minutes when it's done. Holler if you have a problem. So that was on the low end of the care spectrum. All the way up to a patient who received the active interferential treatment, which is theorized to block through gait control pain and relieve it. Those patients received an enhanced therapeutic alliance where the clinician was talking to them about their symptoms. How was it impacting their lifestyle? The therapist stayed with them during the intervention and continued to engage them using all these positive behaviors. So those were the two ends, and the patients kind of received a combination. Do you know that the patients who received no interferential current but they had that enhanced therapeutic alliance, they actually had less pain and better function than patients who actually received a treatment, but the clinician appeared not to care about the patient. Again, brings up the point that these are things that we need to think of. And we need to think that when we're defining quality of care is not just what we do, not just the best practices and the efficient, the safe treatments, which the World Health Organization, historically, that has been the focus of quality. Traditional definitions was best practices, safety, efficiency, being capable. That is what it looked at. It did not include any subjective piece from the patient as to, what message was that giving them? What were they receiving? So now what we're finding is that quality of care, it really needs to be broadened, and it needs to include that patient's subjective experience in terms of explaining things, that the patient's beliefs are going to help gauge the outcomes of therapy, and that it does have an impact and play a role. In order to understand patient satisfaction, we need to look at the components of it. On one side, we have all that technical skill, outcomes, intervention competence. Yes, that has to happen. I'm not saying it doesn't, because it does. What we need to add into that in a little bit more of a conscious way, maybe not. I'm not saying we're not doing it. I definitely have my days where I need to remind myself, that my personal Jody life has to stay at the door, and I have to be on, so to speak, when I walk in that patient room. That human factor is what we're looking at increasing. And the researcher definitely saying that that therapeutic alliance piece is most definitely playing a role. That those, going back to those orthopedic patients that they studied, the ones that had the expectation of, pain relief, not really having complications, that they had a higher patient satisfaction. That when they look at a study of occupational therapists, looked at patient expression of satisfaction with their clinicians and what terminology they utilize. So the patients that gave the OTs high satisfaction ratings, what terminology did they utilize versus those that gave low patient satisfaction ratings? And the high ones, one of the things they said is that they didn't talk to me like I'm ignorant. That they explained why they were doing things. They explained what they're doing. Some of them said they were just enjoyable to be around, so they were, liked coming to therapy more. If you want to take a look at this in your clinic, right? If we want to thicken our skin a little bit, we know our facilities are looking at patient satisfaction, and I would throw out there, when do you look at patient satisfaction? After the patient's discharged. Why? Why wouldn't you want to know that sooner? If we were in a face-to-face class now, if I had all of you in front of me, I would be looking out at the audience. I would be seeing how many of you are falling asleep, how many people are on their phone. You know, are they bored to death? Are they hating this? And I would modify. I don't have that luxury because I can't see your faces, so I hope some of you are still there. um, but so why with our patients do we wait? You know, I would say, why don't you look at patient satisfaction partway through therapy or use some different indicators? And there are a lot of different tools out there that you can utilize. So what I have at the end of the course notes packet is a sheet of references, and in there are all of the different assessment tools that I mentioned, as well as some other resources that I think you'll find interesting. So one of them is the PSQ-18. This is a patient satisfaction questionnaire, and it looks at many different factors, including technical competency, but it adds in this interpersonal piece as well as time spent with the provider, and it's a Likert scale. So you're either strongly agreeing or strongly disagreeing. And some of the questions are things like, I have some doubts about the ability of my clinician to treat me. The therapist ignores what I am saying. The therapist appears to be in a rush or a hurry when they're treating me. The therapist is kind and courteous to me. So things we may or may not want to know, but we need to. We need to ask. So think about some, you know, diving in and getting some of this information when you can still modify for it. And I will tell you, with students in the program that I instruct in, we have a patient satisfaction survey that goes out to clinic with them. And we don't let them pick which patient that they already have a sense likes and loves them to fill it out. We ask the clinical instructor to say, pick the patients you think, pick 2 or 3 patients, and please give them this questionnaire and explain that it's a learning experience and an opportunity, doesn't have a negative impact on grade, and please fill it out. Because the best evals you get are the ones that actually help you improve. Praise is great, and remember that when you do this eval. But you know, we do need to know what we need to improve on with things. We're all not 100% every day, right? Makes a difference for them coming back, for carryover, for so many things. So assessing this patient-centeredness piece, if you want to really look specifically at that therapeutic alliance that we're discussing, there are 2 big tools out there that are utilized: the Helping Alliance Questionnaire and the Working Alliance Inventory. And I would say with these, again, considering just brainstorming here when you would want to use them. It's great for yourself to get feedback. But if you're a supervisor, or let's say you have new hires in those 90 days, maybe you want to get some objective data on this. If someone's not a fit, we all know what that means, right? They're not a fit. But how do you objectify that? Well, maybe this will give some opportunities to remediate or see if they're a match or not. Look at it, you know, when you're working in different settings, again, either for interviewing, things of that nature, where you can use some of these questionnaires for your evaluations. If you're a supervisor, you're new to being a supervisor, and you're kind of struggling with what information to use and where to get it, maybe using some of these tools will give you data to help focus. To give positive feedback and then opportunities for improvement. And again, these surveys are looking at things related to the Therapeutic Alliance. Many of them have been utilized already and adapted and modified to fit the therapeutic setting, even though they developed more in mental health care. So the 2 specific ones we're going to talk about are the HAQ2, the Health Alliance Questionnaire. And this is a self-assessment tool. There's a short form and a long form version, so either 19 or 10 questions that patient is going to answer. And it hits on all different perspectives, again, with that Likert scale. So they're strongly agreeing or strongly disagreeing. And it's going to look at aspects of this bond. So you're going to consider things like, I feel like I am working together with my therapist. I believe that the therapist likes me as a person. So the patient is going to complete that. And then give you some feedback. And again, we may not want to know the answers, but I think we need to. And it's something you could put in context. So again, how to deliver it to be objective and a beneficial thing is something to think about. The working alliance inventory is one that you're going to see utilized more commonly. And the working alliance inventory is used a lot in research also. This one has been found to be the most aligned with the therapeutic alliance, and it's really, from the research, they say that it is the most aligned with the therapeutic alliance. It gives you the best information about the goal, the bonding, and the collaboration, and it's meant to be non-threatening and non-judgmental for the individual. And what's interesting is you can utilize this in some interesting ways. Again, if you have a new hire, or if you have, you're doing evaluations or with students, or maybe you yourself are transitioning into a new setting, you can use the tool where you have the patient complete it, you have the clinician who treated that patient complete it, and then you have an observer complete it. So you have 3 different perspectives of the same interactions that are being observed, and then you can kind of put it together to see how you can utilize that information, see where it takes you. So again, thick skin, but very beneficial, and is the direction things are going. And the focus on this is, again, it is meant to be non-threatening, non-judgmental. The instructions literally say, just think about your interactions and be honest. So that is another tool that you can utilize to assist you. You. Ultimately, where this puts us is trying to get to a position where we are giving 100% that we know we're giving, and our patients are giving that same 100%, so that together we're getting to these goals we mutually agreed upon. And that patient participation is key. And it's something that is important. Theoretically, if the patient is happy and engaged, and they should be adhering and doing what we instruct them to do. However, it doesn't always work that way. That if you think about adherence and engagement, just, in terms of things, picture your last day, Friday that you worked, or yesterday. Picture all your patients. I'm sure you have some of those patients that they just come in, they do what they're supposed to do. You don't talk to them so much. They leave and they're done. And you're like, yeah, I did what I needed to for them. You have other patients where you know everything about their life. You have plenty of interactions with them. They're asking you tons of questions. They understand everything about every aspect of their care. Well, they're doing their exercises too. Both of those patients are able to improve in therapy. However, will one get better a little faster than the other? It's a question that is starting to come up in the research that they're starting to look at. They're considering this difference between adherence versus engagement. And I'll be honest, it totally makes sense when you hear it, but I never really thought about it until I was doing the research for this course and looking more specifically at the topic. So adherence is this. You do what you're supposed to do. You give the patient a home exercise program. They go home. They perform it. They are participating in the interventions while they're in therapy. 3 sets of 10. They did them all. They do all their activities, which is great. They did it on what we consider for that adherence piece is, did they do it on their own or did they need a lot of encouragement to do it? Did you need to keep redirecting them to go back to it? Are they refusing? Maybe they have a good reason, but is there a refusal there? Or they're becoming frustrated and saying, no, I can't continue, or make it easier, it's too much weight. Those are your adherence type things that we need to address. Engagement is the other piece. And engagement is what may, again, personality of the patient comes in, may help you get a little bit of a sense on how much they're buying into everything you're doing. Engagement is, are they actively interacting? Are they really motivated to be doing what they're doing? So this is where, are they asking questions about the intervention? Do they, want to know, well, when will I get to do the standing thing in the parallel bars and step over that stuff and up and down the step? When do you know I'm going to be ready for that? Well, that's an engaged patient. There's an education there. They're motivated. You're tuning into a goal. Why do they want to be able to get up that? Is there something going on that should be one of your therapeutic goals for them? Does it relate to something else in function? These engaged patients are also the ones that they appreciate their own accomplishments. Have you worked with the patient that is getting better, but they just don't see it? They don't feel it? Yeah, I'm walking further, I guess. Or if you're in acute care or skilled, you'll hear them on the phone before you get in the room talking to family. Yeah, I guess I got out of bed for lunch. The family you assume is saying, oh, are you walking further? Is it less pain? Is it getting easier? We go down the hall. That patient, they're adhering, they're doing it, but they are not engaged. So I would say, consider, is there something else you can do to pull that engagement out of the patient? Can't do it for everybody, but maybe is there a different perspective you can look at to get them a little more motivated, to get a little bit more of a buy-in from them? Because ultimately it is going to impact their participation. Make sure your goals are aligned. Because participation is something. So look at those patients who maybe have been construed as challenging and accept the challenge. Or look at the challenge differently when you go in tomorrow. Don't consider that they just don't care or they don't want to do anything. I try to flip it on myself more and consider when I'm having those moments, what am I missing? And I try to find it out. And again, you're not going to catch it for everybody, but something to consider. Look at their function. Look at their social aspects. Is there a way socially you can pull them in? Wow, wouldn't it be great if you had your hair and makeup done when your family came? Let's do, you're working on standing tolerance. You're working on mobility. So see what's important to them to pull it out. Because ultimately, it's their life. It's their goals. That's what we're working towards. When you look at patient participation, another thing to consider is looking at this connection that we have. Have you ever considered that maybe it's time of day for a patient? That maybe morning is better for that patient if they have multiple sclerosis and we live in Florida. Because if I schedule them at 1 o'clock in the peak 105 degrees, and they had to walk a huge distance from their car just to get in for therapy, because of the fatigue and the heat exhaustion, on effect on their multiple sclerosis, as engaged as they want to be, they're just not physiologically capable of that. Maybe consider it. So there are some tools out there that you can utilize to look at patient participation to, again, just give you more information to tease out what's going on to find a way in. And the Pittsburgh Participation Scale, it's a tool that you utilize where you're going to every clinician that works with the patient, they kind of just indicate on a flow sheet the time of day, the date, the amount of participation, the level of the participation, how much help did they need, how much encouragement did they need, and maybe you can look at that and track some patterns to see, is it related to medication, is it time of day, is it person? And again, we may click with some patients better than others. So some tools that you can utilize. What does the research say about this connection? Well, they've looked at it, and they found that looking at physicians and patients who had rheumatoid arthritis, that when there was, the physician said these patients are adhering, they have a high positive scale, that those were also correlated with the same patient saying, yes, I have a strong alliance with this physician. So they saw that because of the subjective being high, the objective participation was also high. Looking at physical therapists and patient with low back pain, other musculoskeletal diagnoses, that the patients felt that when the therapist cared about them and that they had a strong therapeutic alliance, they wanted to improve for themselves as well as that therapist. They again looked at these chronic pain patients, and they found that increased patient satisfaction scales correlated with decreased pain interference and less of an impact on their function. How about if it's not the patient that we bond with? Think of if you're working in pediatrics, if you are in the intensive care unit, it's the family. And you need to remember that you also need to connect with, because ultimately they will be the caregiver. And they're kind of, an extension of the patient. They're part of that satisfaction for you to look at. So they looked at patients in the family members of patients in an intensive care unit, the spouses, the children. These were medically complex patients with 2 or more comorbidities. And they found that if the collaboration was high, that if they felt that the staff at the facility was listening to them, that they were being heard in terms of the needs and wants that they feel their family member would have, and then it was interacted upon, that there was a higher trust level and better interaction, less negative effect, less distress being reported of the family. So there's definitely also an opportunity there to connect with the families. If you're an athletic trainer, look at the athletes. Consider that the research says that athletes are going to look to their trainers or therapists as the individual to give them that emotional challenge. So whether their expectation is too high, too low, that little piece of building that self-efficacy, that they do look to us for that we can prompt them to challenge their beliefs if they're too high or too low, to help mold those expectations. And they say that taking advantage of that is leading to more positive outcomes for that population. So in this big picture, we have a lot of pieces to consider. And where we've been focusing is coming in on this part here. So we're coming in on developing the therapeutic alliance. We all believe it's true. We're going to get the patient engaged, quality outcomes, good patient satisfaction. We're there. Research supports it. How do we actually do that? Because sometimes our message can get lost in the delivery, that what you put out there isn't necessarily what is received. And we've had those interactions. I can remember one patient, and I still to this day replay it in my head, and I wish I could remember the details clearly enough to remember what I missed. But it was in acute care. We were gait training, and we were headed to the bathroom. And I can't remember how we weren't agreeing. I was guarding her, I remember that. And she either did or did not want to use the walker, I don't remember. But somehow that walker ended up in the air and pointed at me, being told to get out of the room. Good balance achieved. Weight bearing status was good. I got the weight bearing is tolerated down. But clearly something went wrong in that interaction in my delivery, because I remember my feelings were, oh yes, we're gonna, get to the bathroom, get her on the toilet, this will be great. That is not what happened. I safely got her back to the chair, but again, somehow our message gets lost. And they've looked at this. specifically in rehabilitation. And it's a complex, combination of factors and events that go in to getting the right message out there. So now we kind of need to look on the other side of things and look at ourselves on how we're creating this interaction. And looking at this technical piece, what we need to consider is they looked at therapeutic interactions. And in considering this complex interplay, they have found that when we look at interaction styles, how do we deliver our message? How do you come across in different situations? That there are actually 36 different ways you can structure your verbal communication or structure your interactions. Looking at just the verbal piece, the words that you use, how you use those specific words, they came up with 17 different ways we can kind of enunciate or relay that message verbally. And then non-verbally, we cannot forget that specific piece, that there are at least 14 nonverbal signals that we give out that can either positively or negatively impact the interactions that we're having. How we engage is really important in terms of giving context to that message that we're delivering. That there is kind of a technical piece to communicating that we need to consider. And this information that I just presented was related to an Australian study where they took some time and they looked at those constructs of the Therapeutic Alliance and which of these pieces come into a play and what's most effective and what isn't. Looking at our interaction styles, the way that we communicate, there are many different interaction styles, different ways we gather information. And we need to do that, particularly on our evaluations. We need to ask both open and closed-ended questions to gather information about our patients and their status. But we also are leaning more towards now being patient involving and patient supporting. So things like what I hear you saying is, that must be frustrating for you. So when the patient tells you these things, to have that come back, to gather more information. And for some people, these things are very, comfortable to do. For others, maybe it's not your first thought, but this is where we need to be thinking in order to develop this therapeutic alliance. For our patients, we want to acknowledge their personal circumstances, that we need to consider that there are other settings that they need to function in and other pieces that come into play. And they've looked at athletic trainers and those that developed an awareness and kind of tuned in to what their young athletes were telling them, kind of reading between the lines about their circumstances and social situations, that statistically they were able to detect eating disorders earlier than other individuals and catch it sooner to have more of an appropriate intervention. Now, new clinicians, or if you're new to a practice setting, tend to speak a little more academically, that they tend to use bigger words. They tend to be more knowledge-based. And then as you get more comfortable in the setting, you feel a little bit better expanding into these other conversations with your patients and building that shared accountability with your patients, which is important. And coaching is something for you to consider, that the research is showing. They looked at patients with osteoarthritis, and for 6 months, they were given a home exercise program and received a call for coaching. And what they found is that when they surveyed the patients after the course of this 6 months, they said that having that phone call, that they didn't want to disappoint the therapist, that because you were calling in and checking in on them, they wanted to have something good to tell you. That it kind of helped to leverage the relationship. So something to think about if you have patients where you're going to be discharging them to maybe continue with the program, consider setting up some follow-up mechanism, at least in the short term. Because the traits that we're looking at, the attributes that we think we all have, are the fact that we're right. We are compassionate. We are respectful and sensitive. All of these positive traits that lead to us being this cheerleader for our patients. which is great. We do need to have these, and it's part of the branding for our organizations. APTA branding kind of is twofold. It says that we are the sage on the stage as well as the hero, that we are balancing understanding where our patients are coming from, but providing interventions for them and skills and techniques to motivate them. The Athletic Training Association pulls in this social piece also by embodying, compassion, empathy for your patients. I have to say, OT gets the award for being the most creative. They use these kind of artsy metaphors, and I love it. It makes me smile when I see it, right? Building a bond already. They have a glass that's full, and this is representing that when the glass is full, we're in harmony. We're full of harmony. The ice cream cone, I forget every time what it is, but it makes me feel good and happy, right? Being the best that you can be. Live life to its fullest, fuel your potential. So we look at all of these different things, and that's supposed to be our motivator, our base that we're jumping from for our patients. We describe ourselves as these people, right? We're people. Think, when you went into the profession, why you did it. You on your best day, what do you look like? How are you? And that's what we're striving for, to treat our patients. Unfortunately, all of the research doesn't quite match up with that. Some of the research is saying that our patients don't see us as this, that we are perceived a little bit more harshly. The word detached, pessimistic, inflexible has been utilized to, look at some clinicians and therapists. Part of it may come, that Nagy model, very linear. Now we got to pull that patient in, or all those different, factors that we have that we're accountable for. We need to think of them, but we need to be aware of how we're coming across. And empathy is what we have to try and deliver. In the end of the course notes, I do have an empathy quiz that you can look at and take for yourself, because empathy is so important. There's two kinds. We have cognitive empathy and affective empathy. Cognitive empathy is looking at, I get the emotions that you're experiencing. In my mind, I understand them. Affective empathy is more a parallel. I physically feel what you're feeling, and I, on an emotional level, react. And those of you that work with children with autism, you know that this occurs in different regions of the brain. Cognitive empathy, as I mentioned, is getting what your patient is thinking. So you can use cognitive empathy this way. Do you give your patient an active warm-up or a modality before they're stretching? Think about if it makes a difference to them. If you give them the modality, are they going to feel ignored, or are they going to be thrilled because they just get to chill out for 15 minutes and that's the only time in the day they can, and they are perfectly fine with not having to be on that bike? Tune into things with your patient. Affective empathy is actually that emotional feeling. It's automatic, it's unconscious, and you're kind of having that actual parallel feeling. So how do we demonstrate empathy to our patients? We're going to recognize this. We are going to try to be aware of our patient and how they're responding. If your patient comes in and they say this, listen to what I'm saying, tuning in. Here's demonstrating empathy. I stopped taking my meds. I stopped taking my meds. Versus the patient that comes in and says, I stopped taking my meds. I stopped taking my meds. Can you hear a difference? Because the first patient, I stopped taking my meds because they make me feel horrible. I feel like I'm throwing up all the time, and I'm in a cloud. I can't work, and I have to work because I need money for my family. That is not a happy patient. That patient is saying something different than, I stopped taking my meds because therapy is working. I am feeling so much better. I am stronger. I don't need them anymore. Tuning in to our patients. Trust is important for us to build with our patients. Don't forget that we're looking for them. They are looking for us to be honest and follow through with things. We need to consider that as we're building that trusting relationship with our patients, that we kind of balance knowledge of their condition and the physiology of it and how healing occurs and the techniques we're using with giving them, that they're a piece, they're a human being in this that we're connecting to. We're going to demonstrate good listening skills. We're going to have a certain level of confidence, but not be overly confident as we're doing this, that we are going to consider how we're coming across to that patient and read them and then adapt to it as we go along. Find things that they want to do, that they are interested in. So in our first hour, we took some time and established some of the patient expectation parameters and how we can help build those. In our second hour, we went more in depth in developing that affective bond with our patients and the positive benefits of that they found in the research. And now in the third hour, we're going to turn things around a little bit and look at ourselves more and continue to talk about how we deliver this message and what we should keep doing that's working well and where maybe we want to switch things up a little bit. What I'd like you to do before I start going back into the content is just take a minute and either jot down or think about making a list of 2 to 3 patients that you treated on Friday. So 2 to 3 patients that you worked with on Friday or yesterday, whenever the last time was that you were in the clinic. And if you were going to write a list of those, just jot that down and hang on to it. We are going to come back to that in a little bit. Before the break, we were talking about establishing trust with our patients and how that is so important to get them to believe in this great therapeutic alliance that we are building. And empathy. It's important for patients to believe that we are connected and want them to get better and are hearing what they're saying. But how do we know we're accomplishing that? There are different questions that the research is saying can get at that information for you. And if you're, again, working with new hires or doing evaluations, or even you want to self-assess yourself and do a little check on where you stand in terms of your building empathy and a relationship with patient, ask yourself these questions. Describe a situation or a patient where you learned something new or realized something important concerning the interaction. Sounds like an interview question. You could use these for this also. It's a tough question. Because if your first instinct is to be very technical on this, and every example you think of is related to mechanics or an intervention or a treatment, and you're kind of losing the patient and the person in it, if you can't come up with an example like some of them that I've used where I used information from the patient or had to change my approach, maybe consider that you could expand your empathy a little bit more. Are there factors that might disrupt a good interaction with a patient? Yes or no? Do you think there are factors? And then explain why. So these are things to think about because, again, we have to be a little introspective. We have to broaden our perspective and be able to describe what's a good interaction. So again, just some things if you want to do a little self-check or maybe in your supervisory role or with students, things that you could utilize. Interview committee, right? You'd be very interested in the answers to some of these. And in healthcare, a lot of organizations, they're using behavioral interviews. It's becoming more about who you are and how you react. Because the technical skills, everybody gets the basics, and some facilities feel they can teach that. They can't change how someone comes across and if they're a good match or not. Which leads us to personality style. And when we look at personality style, that is considering our beliefs and other factors, how we present ourselves verbally, how we carry ourselves, which are a little harder to quantify. And there are some different types of studies or tools, I should say, that are utilized as personality type of inventories. Often they're self-report type questionnaires And one of them that's utilized extensively is the BFI, Big Five Inventory, which is a personality assessment tool. It's a brief survey. It's multidimensional. There's like 44 short phrases, and then you are going to kind of rank yourself as strongly agreeing or strongly disagreeing on a Likert scale. I included a link to this in the back of your packet, so if you want to go figure out your specific personality style, let me read you a sample of what some of the questions are like. You rank yourself, and then it calculates out your personality style based on your answers. So sometimes I say, when you complete these things, complete it twice, maybe once with how you are at work and once with how you are at home. And then I would even say, have a family member complete it or a coworker and see what they would say of how you actually come across, just as a fun comparison. Because sometimes I like to say the way work Jody handles something is a lot of times a lot more tactful and pleasant than the way home Jody would be handling it. And that's okay, right? But here are some of the types of questions it asks. I see myself as someone who can be somewhat careless, starts quarrels with others, can be tense, values artistry, can be moody, tends to be quiet, is emotionally stable, not easily upset. So it asks a bunch of different questions. It's not asking you if they're positive or negative traits. It's just asking you about the traits. And then what this tool does is compile all of that information, and it produces a personality style. And it produces 5 different personality styles. So just some examples. And the reality is there are different times to use each of these. So it's not like a test in school where, well, what's the correct answer? What's the best style? There are different times to use different ones. And some have been associated with poorer outcomes when overutilized. So we're going to take a look at that. So let's say you're someone who is open to experiences. You're very complex mentally thinking. You tend to be a little more experimental, imaginative, intellectual. So depending on what patient population you're working with, maybe in pediatrics, that's really, really great. Or maybe with complex patients, but maybe in acute care where we need to be a little more basic. Can you get up out of bed? We're, in terms of the tasks, right? We're not taking them down to the gym to do very dynamic interventions in the parallel bars. You're going to use that creativity more at the bedside to accomplish what needs to be done. Someone who's high on the conscientious scale, they're going to be very achievement-oriented, tasks, goal-directed, maybe a little more cautious, but very reliable and dependable. That extroversion, which some people may view as a negative, it is not in this scale. These are just the traits, and they're not viewed as positive or negative at this point. Someone with a high extroversion scale, they're a lot more gregarious, very active, maybe positive emotion, not necessarily in a negative way, energetic, social, and sometimes you need that based on the population you're working with. If you're working with a patient who's had a traumatic brain injury and has high tone, you're going to need to take it down a notch for that patient. But if you're working with that really low tone patient or that child who has really low tone, maybe you're going to pull out your extroversion a little bit more. Someone who's a little more on the agreeable side of things, they tend to be sympathetic, forgiving, flexible. And then neuroticism tends to be someone who is a little more worried. They look a little more less emotionally stable, not as even tempered, high neuroticism. So what does the research say about these personalities and how they relate to therapy? in terms of clinicians, what they found, and there are a lot of different studies that look at this, so it's not a blanket rule. Don't get a score and say I have leave the profession. But look at it as if there's a high agreeableness, conscientious, extroversion, and openness, those are the ones we tend to see in clinicians and in medical professionals. Whereas neuroticism tends to be on the little lower end of the scale. Those are not the most beneficial traits in healthcare, because those tend to be more the individuals who are expressing unpleasant emotions. They don't have a very calm and relaxed personality, which doesn't necessarily lend itself to the therapeutic environment. That therapist effect does play a little bit of a role in our interactions. Actually, we were talking today that it plays kind of a significant role in the interactions. The research really varies on quantifying how much. You know, like, well, if I'm really good at my hands-on techniques and I'm really good at developing a goal, if I'm not such a, happy feeling person 20% of the time, is that okay? The research doesn't look at it that way, because honestly, it's going to depend patient to patient, right? We're adapting our interactions as we go along. And today is just really a discussion at, feeling comfortable doing that and looking at the different pieces. The goal is you want to leverage all this information, not only for your patient, but also for yourself, so that you have a high job satisfaction, so that your colleagues are having fun being around you and want to continue to come to work. If we look at this therapist effect on patients who have different chronic diseases, they're finding that it does play a role for the patient. Things like rheumatoid arthritis, which is more of a long-term condition, or someone with fibromyalgia, where their pain levels and endurance and ability to function will fluctuate over time. Even your respiratory patients consider this, that they have long-term chronic condition that is going to impact their endurance and their ability to function. It may not be why you're treating them. Maybe you're seeing them for a total joint replacement, or an ankle sprain or carpal tunnel. But they also have this other comorbidity that impacts their big picture and their idea of the future. And what they found in looking at individuals who have these chronic diseases, they evaluated, I want to say it was around 400 patients who were treated by about 39 different occupational therapists. And they found that the clinicians who had high neuroticism traits, that they themselves tended to not be as calm and confident and even-keeled in things, that there were decreased therapeutic outcomes for those patients. Whereas the ones that were more approaching the patient from a coaching perspective, kind of looking at the issues and challenges that they face because of their history and incorporating this into the goals and considering the whole patient, not just that wrist, knee, ankle that's coming in, that also had low neuroticism values, were able to do that in a calm and focused manner, that those patients had better outcomes from therapy. And I say this is something to think about because we all have those busy days. I've worked acute care where, those evals just keep coming in. If you've worked season in Florida and it's 3 weeks before a holiday, everyone's getting their total joints done and they want to be out and home, and it is busy, right? And then you guys get them all in outpatient and home care. So for ourselves, we have to keep that in check and leave it at the door when we go in to see that patient, because the research says it does spill over. If we look at patients who have anxiety and mood disorders, what they found in clinicians that they work with, and this is a little bit more from a mental health perspective, that if the therapist had a significant extroversion quality, where they were more outgoing and gregarious with things, that those patients in the short term, they had faster improvements in their outcomes. That really outgoing, extroverted therapist was able to make really strong short-term gains with those patients. But then they looked long term and they found that that gain was not maintained, that the clinicians who were a little more cautious, not as intrusive in terms of gathering information, they went a little more at the patient's pace with things and developing the bond and expanding to new things, that those patients had greater long-term benefits. So I think for ourselves that we all probably possess all these different traits, and we may need to tap into them at different times during our rehab with patients. And we mentioned when talking about patients in intensive care that sometimes we are not the only ones that are having influence on their interactions and ultimately their function in daily life. That for many of them, there's a caregiver who there needs to be a good working relationship between the patient as well as their caregiver in order for them to have a positive outcome from rehab. So they went ahead and they looked at patients who were having a CABG, coronary artery bypass graft, and their families. And pre-surgically, they did some personality assessments of looking at the caregiver, the spouse who was going to work with them when they got home, and the patient. And they considered their neuroticism levels, that, kind of a more emotional temperament, that being maybe a little more angry, worried, concerned, on the negative scale in terms of those emotions. And what they found that when the caregiver had high neuroticism levels as their personality trait, that it actually post-surgically in those patients, they saw greater depressive symptoms in the patients. And then combine that, if the patient themselves has that neuroticism trait, then you're, compounding those depressive symptoms potentially in the patient. And then we're coming in and we're going to need to help balance some of those things out. We're going to have to tap in, recognize if this happens to be occurring in select patients, well, what are they so concerned, worried, anxious about, so that I can gain their trust, let them know that I empathize, and let's set some goals or equipment or strategies or external support, referral to other sources, whatever they need. Because if that patient slips into a potential depression, where not only emotionally it's not beneficial, but depression has physical symptoms where they don't want to be as active. If they just had a CABG or a major surgery, that's going to impact their recovery and increase their risk of complications. So we're looking at this from a bigger perspective. In the process of doing all of this, we need to think about ourselves a little bit. We need to remember that burnout is a concern for us. This is a lot weighing emotionally on us. Burnout, by definition, is emotional and physical exhaustion resulting from a combination of exposure to environmental and internal stressors and inadequate coping and adaptive skills. And yes, right? It can definitely happen. And it's a concern in all of healthcare, not just in rehab, in many different disciplines. There's a concern that if clinicians burn out, they become emotionally exhausted so they can't effectively continue with their job. If they leave the profession, you don't have all of those experienced clinicians there anymore to mentor the next generation for all of these different potential benefits, right? That they call it a brain drain, you may have heard, compassion fatigue, that if we have individuals leave the profession, then who's left to mentor the next generation? Who you're left with then are a cohort that are still, trying to figure it out. That's what happens to all of us when we're new graduates, or sometimes if you just transition to a new setting, or you left the profession for a little and you're coming back. Or maybe your load increased and they're just more complex. We need to rely, because our tendency is going to be to revert back to being more of that biomedical model, that NAGI, versus that psychosocial model. So you need the experienced individuals there to kind of mirror behaviors and help. So how do we know if someone is starting to burn out? Even so we could do a little self-check of ourselves related to this. Some things that you can look at is emotional exhaustion. We know what that feels like, where you're just emotionally, drained. But some other things to think about is if someone starts to depersonalize their patients, that could be an indicator that they're starting to lead towards burnout. That they're kind of detaching their feelings from the patient. So instead of, oh, I have, 12 patients to treat today, 6 of them have had total knee replacements, 6 of them have had total hip replacements, it's like, I have to go see the knees in 524 and 526, and then I have to get them in the CPMs so that there's time to see the hip in 524, and they're no longer people, right? So that might be a sign of depersonalization. If as clinicians, we're not satisfied with our accomplishments, if we can't see, if we're saying things like, oh, I just do the same thing every day, or, oh, in this setting, I don't have to think, I'm just on autopilot, I just do it. I ponder if that's what you feel yourself thinking, and not that we don't have moments, but you need to catch yourself, because there is something different about every patient, whether it's just what we talk about today or their comorbidities are not exactly the same. The height of their bed at home is not exactly the same, so that makes bed mobility and getting in and out different. So just be aware of that. If you lose your personal accomplishments, if you aren't seeing that you're making a difference anymore, that should be a little bit of a red flag to you about burnout. So just something to think about to avoid that for yourself or other colleagues, so you can gently broach it to help interact. Looking at different associated traits, this was an interesting study. One of them that I had read was looking at that individuals who have a high level of agreeableness, those are the go with the flow people, they're very flexible, they adapt, which is great, and they're very conscientious, they actually have low satisfaction scores. So that's placing them at a greater risk of burnout. And they particularly found that in therapists working in the school setting, that this was the case. High agreeableness and conscientiousness fits well with that situation, and adaptability because of the environment and schedule and things of that nature. But they had low job satisfaction, and what they attribute it to is there are many things out of their control. So they're fighting for these kids to get what they need, but maybe the system wasn't working with them. So it led to decreased job satisfaction that could potentially loop back around to impacting that effective bond. So something to think about. They've also found that physicians who are more sensitive to patients' emotional cues in that little bit of time that they are with them, that they're better at catching anxiety and depressive symptoms that are associated with their conditions so that they can manage them and treat more holistically. When we put all of this together to employ our patient-centered communication, it hinges on us delivering that message appropriately. What I want you to do is look back at that list that you had made of patients that you worked with yesterday or Friday, or reflect back on your mental list. And if you wrote things like ACL, CVA, THR, if you put diagnoses, pathologies, and you didn't put a patient with, or someone who had. Now you might be saying, oh, it's because I just did it shorthand in my mind. That's how I thought of it. That's great. We need to be aware of this people first language, and this is a big push in healthcare, that we're going to look at individuals as people. It is not an ankle wobbling in here that is not connected to a person that has likes, wants, needs, their own stresses, their own factors on them. You know, that insurance reimbursement that you're struggling with, what CPT code do I put, and how many minutes has it been, and what can I bill for? That bill is looping back around to that patient, and they have to have a job that they're not at because they're there with you in therapy to pay for it. So again, looking at our patients holistically. There's been a lot of research that says the best way to start developing that therapeutic bond right from the get-go is to shake a hand, introduce yourself, and confirm the person's name. Use their name when you talk to them. And I will say, I am not a name person. I am not great at remembering names. Someone will tell me the name and like 5 times in my head, I'm repeating it. And 10 minutes later, I'm like, oh, who was that? Like, I'll remember everything else about them. But in healthcare for patients, it definitely makes a difference. Hello, Mrs. Jones. Nice to see you. I am. That sets things off on the right foot right from the get-go. Something else to think about in therapy is to sandwich our feedback to our patients. We are great because as clinicians, we are problem solvers, right? That's why the patient came to us. They are unable to get in and out of the car. They can't bathe themselves in the shower. They have too much pain. They can't sit at their desk all day for work. They've had an amputation and they can't walk now. We are going to figure out why. We are going to data collect to confirm it, and we are going to hone in, develop a plan, and fix that. That is what we do. And we pull in this whole social piece. We have to remember that when we're giving feedback to the patient, that we have to, gait analysis is a perfect example, and I can think of one particular patient where she was doing really well with gait. She was ambulating with her walker, I don't remember if it was total hip or total knee, but I can remember the moment walking in the hallway. I was guarding, looking at her gait pattern, and she was doing so well that I was able to really start fine-tuning it because I wanted to get her off of the walker. So I wanted to get her out of that anterior pelvic tilt I saw she was starting to fall into. I wanted to increase her stride length, get a good heel strike for surfaces. So I would say things as we were walking, use a little tactile, okay, let's have you stand up nice and straight. And then, oh, okay, so when you step with that left leg, make sure you lift it up and step it all the way out and put that heel down first. So I'm tweaking it, and I am so excited. And then afterwards, I said to the patient, I said, that was so great. I said, you're walking so much better. I'm thinking we can maybe try a cane next session, and I'm excited. And the patient's like, really? They're like, you were like fixing and correcting and telling me I was doing so much wrong that I didn't think I did well. And it was an aha moment that totally is not sandwiching the feedback. I was in the middle of the Oreo, right? Giving not negative, what could be construed as negative, the things we needed to fix, and I forgot to give the positives on either side. So working with that patient in subsequent sessions, I started out more with, because you're doing so well, because you are gaining strength and can lift that leg up, now the next time you put it down, let's try the heel. And then I'd give more feedback. Yes, that's good. See, now you're putting your heel down. So I tweaked it. Sandwiching feedback is positive, what to work on, finish with the positive. Happens, right? We need to bear these things in mind. Patient interviewing is a skill to develop. It takes a little bit of time. So when you're developing your patient interviewing skills, and particularly for new clinicians, the APTA came out with the ECHAL tool that helps clinicians go through a process of not missing anything in the evaluation, and it incorporates elements of recognizing building the therapeutic alliance. So it's a pretty long tool, but it tells clinicians how to go through establishing a rapport, interviewing the patient about their complaints and their history, and then pull in the social history and reflect back on things. This is a tool that can be utilized to help not miss anything, and it provides some summary at the bottom of it to assess how the message was delivered. The tendency is when we communicate, we have to look at our affective versus our instrumental communication. Affective communication is, its intent is to kind of look at the listener and the speaker and to show that you're hearing what they're saying, that you not only heard it, which it went in and your brain recognized them as words, that you made sense of those words, you used your empathy, and you are considering what they're saying. You understood it, the emotion behind it. And the things that we use to do this are more emotional probes. We look at reflections and feelings. So how do you do that? You may say things to the patient like, I see this upsets you, if they're talking about something, whether it's function or personal life that leads you to a referral, or that must be frustrating. So that to the receiver shows that you are understanding it. And what they've done in the research is they videotape therapists and patients interacting, and then they pick apart the interactions to see what works well and what doesn't. And what they found are things of saying, if a patient makes a statement and you want to see, well, where are they coming from with this, or what can I do with that information? How's it going to be helpful in therapy? A nice follow-up question is, what makes you think so? So particularly if a patient is expressing they can't do something or don't, or something's not going the way it should, or something negative, what makes you think so? These work well with teenagers too. I've been testing them for several years now. Not always the answers you want, but you can try them. Explain what you mean by XYZ and repeat it. Can you go further into that for me? So this may be where you can get more information out of the patient. I can think of a patient who had cervical stenosis and significant motor weakness in her hands, numbness, tingling, and she was having difficulty opening bottles, grasping the walker, things like that because of her cervical stenosis. And whenever I would interview her about what was going on, function, asking things, she would just always talk about the weakness in the hand, which I understood. So my goals were related to that, but all my interventions were focused up here in the cervical region, because that's where the problem is. Well, at some point I realized that the patient kept asking, when are you going to work on my hands? When are you going to help me? And this is during one set, the initial evaluation as I'm focusing on the neck. And I realized I wasn't clearly communicating enough that the problem is up here, the cause, but the symptoms down here. So for that patient, she didn't think I was hearing her. I needed to change my communication to let her know. So when I explained more about that it was the nerves in her neck, so I went a little biomedical briefly, then she was able to get like, oh, that's how it's going to help my hands. So you did hear me. Where we don't want to get stuck up is too much instrumental communication. Instrumental communication is more clinical kind of speak, that it's just putting more information out there, that we want to make sure that the patient knows that we're hearing what they're saying. We just don't want to be speaking over their head. We don't want to be all technical. And they've done research. And when we do evaluations as clinicians, compared to when all of us, assistants included, do treatments, that we tend to do a lot more instrumental talking during the initial evaluation, because we have to ask questions. We need to know medical history. We need to know goals. We need to know all these different things. And what you have to look at is maybe adding things in that'll give you that information and couching them away to be less instrumental and a little more affective. So asking things about self-management, sleeping position and sleeping tolerance, ergonomics, things of that nature are opportunities where you can get the information you need, but also, intertwine a little more affective communication in for your patient, and then also tie that into your goals and you're building your bond. and listen to the patient's words. Listen to what they're saying. If they're using the words I think this, that's what they expect is going to happen. I think therapy is going to help me. I think I'm going to be able to go back to work. That's what they're expecting. Versus I would like or I want, those are going to be ideally. That's the dream. Should is where we can focus. Should is where we have a good opportunity for short-term goals. If you're giving patients feedback and you give them those little mini points in time to see success, it can be beneficial. So if you're doing this treatment, I just had a patient the other day who was having difficulty crossing her legs to put her shoes on. So I thought for sure that it was tightness in the sagittal planes of hip flexion, but it wasn't when I assessed her. When I looked, it turned out to be piriformis tightness. So anyway, problem solving it back and forth with the patient helped develop the bond. I'm like, show me again how you're trying to do it and why you can't get it there. She couldn't get her leg crossed. So I gave her a piriformis stretch, but I didn't stop there. What I did was when I put her in the piriformis stretch position and hook lying with the other leg crossed over, I said, look at this position. I said, do you feel that? Where are you feeling it? Show me where you're feeling it. I said, is that the same thing you feel or that's stopping you when you're trying to put your shoe on? And she's like, oh, yeah, it is. So I said, so see, this lying down here is going to ultimately help you get your shoe on. So this should help. You should feel it here in that same spot. Give the patient little expectations, just one example. We're going to use the active listening skills as we work with our patients. That you are going to take a look at communicating with patient, let them know that you're hearing what you're saying. Don't be completely distracted with writing everything down. Give them feedback during your data collection. Is that normal? Isn't it normal? What do we do when we go to the doctor and they're checking our vitals? We are all looking at those numbers, processing in our head what we think is going on, and when that doctor comes in, we already know kind of in our heads what assessments we think he should be doing, right? Because we ourselves are pulling that feedback. And if you can't see the monitor, don't you ask? I do. Maybe I'm annoying. I don't know. But I'm doing that in my head. So our patients want that too. Don't just do your data collection and your interventions and not give them feedback. Let them know, is it what's expected? What should be going on? Help them kind of formulate where things are heading so that, again, they're part of it and they are being part of the team. Sometimes we need to redirect our patients, that if they're going off topic a little bit on things, we need to pull them back in a little more. And I would say, don't assume that a patient who's rambling on about things that you're starting to tune out, that they don't have a point. They may just be getting there in their own way. I know we need to balance getting things done with listening to the patient, but some patients, they may have a point, and what they continue to loop back to as what may seem like a complaint or a problem or taking forever to get to the point, that they might be expressing dissatisfaction, or there might be a functional challenge that they just can't put into words, that we'll be able to, if we step back, see the connection between. we do have to look at the cues that we're giving and the cues that are, paraverbal cues they're called. That 55% of the message that we give is nonverbal. 38% is from the tone of our voice, and only 7 are the words that we're using. So we really need to think about these factors. Again, what we're saying is important, but how we're saying it is important too. And that's how we're coming across and what we can pull from our patients. So think about this. If you ask your patient a yes/no question, let's say you ask them, so, hi, how are you feeling? All of that. You say, so how are you able to do the exercises that we put together last time? If the patient says something like, yes, yes, see how it gets high on the end? That patient, even if you didn't see their facial expression, they're communicating to you enthusiasm and happiness. And yes, you're saying yes, they're doing the exercises, it's going well. Yes to closed-ended question. If you get something more like, yes, yes, see how it goes, yes, kind of has that little tail on the end of it. What they're saying is, yes, but maybe I'm not doing them as often as I should. Or maybe they're causing me pain. Or maybe I don't really know what I'm doing. I don't think I'm doing them right. Don't just stop at the yes. Hear the yes. What if they say something like, yes, yes, where it's more of a low pitch kind of thing, below a normal tone? There's something dissatisfaction there, or negativity, or a problem. Doesn't mean they're doing something wrong. Maybe they want to be doing it, but they're just too busy. So let's say it's a cervical patient and you gave them this whole isometric program to do every morning, but they're getting the kids ready for school. They can't do that. So then they have cervical pain all day at work when they're at the computer. Maybe that patient, if you question them down the right path, you figure that out, maybe when they're in the car, they do their chin tucks, right? While they're waiting in car line, you modify the program, or you plant the seed that that's when it can be done. So listen to how the patient is delivering their message to you, because it'll give you some helpful information beyond what the words. Kind of works both ways for us. Also, looking at nonverbal cues that we give, look at if the information is reinforcing what the patient is saying or if it's contradicting it. If that same patient is saying, yes, I'm doing my exercises, and they're looking down and they're like this, they probably just don't want to tell you no, because they know it shouldn't be no, or maybe look at how you asked it. Maybe did you intimidate them a little bit, or you being accusatory that it's their fault they're not getting better, and you need to couch that a little differently. So look and see if the nonverbal is matching the verbal piece that the patient is saying. Also consider when you're matching things up, sometimes the voice and the nonverbal in the words are not going to match. And this is where we can have an opportunity, again, putting the different pieces together. That if a patient's voice sounds very croaky, and we notice that over time, that could be a sign of reflux. Maybe that's exacerbating for them. So maybe because their reflux is exacerbated because they're so busy squeezing in therapy and they're hitting the drive-through, lying supine to do their exercises, that's really not going to work for them because it'll exacerbate their symptoms. Another way to just think about putting things together. If a patient sounds more congested, maybe there's something sinus going on and that is relayed in their voice. A deeper, weak voice is thyroid. Your patients with Parkinson's disease, they're going to have a flat affect, and the verbal is going to be a little more of a challenge for them. It's going to be more monotone. So you need to tune in different ways. So look at more of the nonverbal cues for the patient to pull a little bit more information from them. We're going to take a look at some nonverbal cues and see if you can pick what is a real versus a fake smile on a patient. So let me just copy something here. And we're going to see if this is a real or a fake smile that this patient is demonstrating. I'm going to copy a link here, and you will see it appear in the right-hand side of your window momentarily. Let me click this up. So looking at real versus fake smile, right? Because we use a smile a lot to give us feedback on, input on what a patient is thinking. So take a look at this patient's smile, person, I should say, and I want you to think, did he do a real or a fake smile? Let me rewind him again. He smiles fast. So take a look to yourself and think, do you think it's real or fake? That gentleman is actually demonstrating a fake smile. That was not real. Some of the things that you can look for in the smile, and I included the link for this, is in your end of packet. So if you weren't able to say it, so the end of the packet has this real or fake smile quiz that you can take. So that gentleman was actually demonstrating a fake smile. And what you look is that when someone is doing a fake smile, the zygomatic major tends to pull the corners of the mouth outward, and the teeth tend to show on the bottom. So I'm like, you're really happy to be here. The teeth on the bottom are going to show a little bit more if they say it's a fake smile. Versus a real smile is going to be evidenced if the cheeks pull more upward versus retracted. The orbicularis oculi, you get a little bit of eye wrinkling, and the eyes tend to close a little when it's a real smile. So some things you can look for. And again, if the link didn't show for everyone, I think it's because people were trying to type in answers, so don't worry about it. I put this whole quiz, there's a bunch of them that you can do in your course notes packet to decide if it's a real versus a fake smile for the individual. It's kind of fun to do to see if you get it. It becomes like a challenge. Also looking at our nonverbal strategies that we're considering for our patient. Some nonverbal strategies that you want to, let me click back here. Nonverbal strategies that you want to use are matching your gaze. So eye contact, some people are not comfortable with it, but it is important that you maintain eye contact. You're not staring. So this is not good eye contact, just staring intently at someone, but kind of matching the gaze of the individual. Leaning in, we know, is going to be, gesturing and facilitating a positive relationship, keeping our bodies open and relaxed. Some of the nonverbal strategies to avoid, do you guys know about the fig leaf? That's the individual when they sit, they take their hands and they cover their genitalia at the pelvis. Kind of like, a fig leaf covering and protecting things. That's someone who's nervous, they're trying to protect themselves. Someone with closed in body, crossed arms, crossed legs, they're closed in. Those are negative communication. We need to think about that with documentation now. If you're using documentation on electronic media, if you're here and you're very like this, very tight and closed in, and your legs are crossed, and you're looking at this as you're talking to the patient and you're writing, that very symmetrical, tight, closed in posture comes across as negative, and you're not making eye contact. So even just having an asymmetry to your posture, not compromising your ergonomics, which is something else we'd have to talk about, but have a little, asymmetry to things, holding it, but not holding this in front here, maybe as a block, holding it to the side, so you're still giving the patient your attention, and then orienting to this, give me a minute, and then back to the patient. Some things to think about with body language. Also consider that touch is important. We use different types of touch in therapy, that when we are communicating, instrumental touch is very specific for a technique, versus our affective touch is going to communicate more of that empathy, that emotion, that connection for our patients. And you need to get their permission for that. Think about your distances. The new estimation of touch and distances, getting into someone's personal space, is that if you're a 2-fist, distance from someone, that is considered in their personal space. So we need to get permission to get in there, because that's where we need to be for therapy. But it's also very emotionally intimate. So be aware of that. Sometimes you want to engage that. Other times you need to work your way into it. If you're a handshake, distance away from someone, that means it's friendly. So that's usually where we start with our patients. And if you're 2 arm distances or an arm distance away, that's usually someone you don't know as well and you're creating more of a gap. So again, think if you're documenting during your treatment or you're going back to, among different patients, think about the distances that you are utilizing. Something to think about with breaking the tension for our patients and for ourselves. There's this mirroring behavior, and they say we have these mirroring neurons in our brains. And if you copy someone else's body language, that will help them feel more relaxed in the situation. So something interesting to try. So if you, where this came from, I guess I should tell you, is they did studies on monkeys, and they looked at monkeys who were given a banana and were eating it, and they monitored their neuronal patterns, and then they monitored the patterns on a second monkey that was watching that other monkey get to eat the banana. And they found that the same neuronal pathways were firing in just watching the behavior. So the emotional response was similar. So something to think about with your patients to maybe mirror their body language a little bit if that's going to help break the tension and kind of drag them in. Another aspect to consider if you're working with any population, but athletes or someone returning to work, or if you're in pediatrics, whatever it may be, is the benefit of the, kind of power posture where someone sits up straight, the chest is out, shoulders are backed, neck is aligned, that kind of power pose. They did studies of gamblers and they checked lab values along with it. And they found that those who took a 2-minute, assertiveness power pose, that there was actually an increase in a 20% increase in testosterone, 25% decrease in cortisol, which is our stress hormone, and that they found the gamblers became a little bit more of a risk taker. So it had a positive benefit. So maybe your athlete before they get on the field. Even my patient, I've even used this with my patients following a stroke, that we're getting them up, we're going from the parallel bars to that assistive device for the first time, and they're a little nervous or anxious. So I use my handling techniques to help them get up in that power pose. Maybe I even tell them that's what we're doing. I'm like, come on, let's get you ready. Let's get set. Think about it. Envision. You're up. You're ready. You can do this. Try to tap into a little bit, and then when they're ready, take that first step. Lots of different ways you could think of applying the information that we've covered today. Your goal is to create that collaborative working relationship with your patient that is beneficial for them and makes continuing in this session enjoyable for you also. That brings us to the conclusion of our presentation. And what we're going to do together now is take a look at the post-test. I'll read the questions, I'll put it up, read the questions, and we'll come to consensus on the correct answers. Once we're done with that, I will give you the information on how to actually go and complete the post-test and submit your payment. So for now, what we're going to do is take a look at the post-test. What is the best advice for when a patient has a very unrealistic goal? You need to read the patient also. See where that unrealistic goal is coming from. I am by no means an expert on this, just some ideas to throw out and think about. See where the unrealistic goal is coming from, and are you the best person to be addressing that? I have worked with individuals with spinal cord injury where their outcome for recovery, it's a little more of something for the physician to address. So that might mean a collaboration between both of you to address that with the patient. And sometimes it's negotiating with the patient if they have an unrealistic long-term goal. Well, let's look at a shorter-term goal that maybe is manageable. And sometimes consulting with other professionals is necessary. So someone is asking for the statistical information that I am referencing, and I apologize, I forgot to mention this. All the research studies that I utilized to create the course and that I referenced throughout are included in the references at the end of the course. And they are always things that are out there for free, so you don't have to pay for them. Next question is, are patient satisfaction surveys done in all settings? That's a good question. I would probably say no, because it would depend if that's data that your facility or company. I've noticed that there are more wellness clinics opening. Could this be the future for collaborative relationships? Who knows, right? I have seen the pendulum swing in many directions in my career. I think collaboration is good among professionals as well as including our patient in that. We are all, if we're all focusing on the goal of improving quality of care, it's good to be open-minded in how we can accomplish that. That function goals help the patient to participate. Most definitely, I completely agree. Function is a focus. When I write my goals, I've gotten in the habit of not writing, increase hip flexion to 4 out of 5 and stopping there. My pen continues to ascend the stairs or to get in and out of the car, or kind of closing the loop on that piece. Again, writing goals, though, it is going to be a factor you need to consider related to reimbursers, practice settings. So there's a lot that goes into how you're going to specifically phrase those. But considering function is definitely an important factor. So someone's asking the question that looking at the clinician, the PT, PTA, or OT CODA relationship, that sometimes the patient does not want to be treated by the assistant as they view it. And that's a big topic, lots of ways to tackle it, and looking at in light of what we're discussing today. Is it the specific individual that they don't want, that's not their preference to be treated by, or is it because the individual is the title has assistant in it that they feel they're not getting the expert, so to speak? So for some of it is, there'll be those patients that, right, they want to be seen by the physician, not the PA. So they want to be seen by the PT or the OT, not the assistant. And that's just their mindset. But in light of everything we're talking about today, maybe there's an opportunity to look at, is there something different in the interaction, or not in the interaction that has actually happened for them, or they may not have even been treated by an assistant before. Maybe a friend had an interaction. So maybe trying to find out for that patient why they're not accepting it, so that you can look at a way to find your way in, to see what the missing piece is. And we'll hit on a lot of different personality, interaction, discussion things today that maybe it's one of those for the patient. That's the trigger. And when we have patients that present with pain, generally speaking, what should happen is that the individual is going to, experience their injury, they experience pain, They're either educated or they just understand why they have the pain, they confront it, and they deal with it and they recover through their treatments. Typical course for many patients. For other patients, they fall into this fear avoidance model, and that is our chronic pain patients, that the way they interpret pain is different. And what happens is when patients experience pain, some of them undergo what's called pain catastrophizing. They see pain as a threat, that they feel that they do not have control over it. They don't know what's going to happen, and it leads to this fear, concern, and worry. Well, because of that, they are going to be hypervigilant. They're going to avoid activity. Well, if they're doing less activity, the muscles are going to tighten down more. They're going to have more postural shifts that maybe if it's back pain places pressure on that nerve root. Maybe they're gaining weight now, so there's increased weight that's occurring that is compromising their pain and exacerbating their arthritis, whatever it may be. Now they move less because it actually does hurt. Now they can do less, so maybe depression sets in or other psychological factors, and they fall into this vicious cycle of the fear avoidance of pain. And because they fall into this cycle, they are never able to attenuate their response to pain because they fear that it's going to hurt when they move. So they don't move, they have musculoskeletal changes. So guess what? It does hurt more for that patient. And they anticipate that pain, so they have a negative expectation, and guess what? That negative expectation is fulfilled. So it falls into this cycle. And what they're finding is that lots of different ways to tap in with chronic pain patient, and that's not the focus of today, but it's something that I wanted to bring up because the research is looking at that mind-body connection and everything that we're talking about through the alliance and expectations. Is there a way we can tap in more for these chronic pain patients to help break this cycle for them, to help minimize their fear and their maladaptive strategies so that we can make gains? If you look at the difference between adherence and engagement, and I really hadn't pondered it before I started reading the research, but there is a difference between adherence and engagement. Adherence is that patient that comes in and they do what they're supposed to do. You tell them to do their exercises, they do them. Are they doing their home program? Yes, they're working on it. The patient who is engaged is asking questions. Well, when am I going to get on the bike? Or, oh, I noticed that other person, they are doing exercises standing up. How do I know when I get to do exercises standing up? They're more engaged. They're thinking about the future. They are more involved in their course of therapy. So it's okay to have patients at both ends. Some are just going to do what they're supposed to do. Some are going to be more engaging and interested in it. Ideally, we would like that engaged patient. Reality is that patient who's just adhering, they are going to get better also. If you want to increase participation, think about ways to bring adherence to the engagement level. So let's say your patient, it's a cervical patient and they need to do chin tucks. Well, maybe talk to them and say, for many patients, I have them do it in the car. Because that's when, I say, okay, when you're sitting at that traffic light that you're at that lasts 4 minutes, I want you to do your chin tucks at that time. Because maybe they're too busy in the morning and they can't do their exercise program. So there are times where you can negotiate with your patient that compliance, particularly for a home program. If your goal is just to have them do some kind of cardiovascular at home, ask them, walking, biking, walking in the pool, what's going to work better for you, what time of day, and develop this relationship so that there may be other options. That particular protocol that you just come up with, it may not work for everybody, and we know that. So having this discussion not only builds the bond, but it may get better participation out of your patient. Someone's asking, how much importance does the research indicate the relationship with family plays in the process? And they are finding that the relationship with the family does play a role, particularly for patients in the intensive care unit, critically ill patients, that if the patient if we're unable to communicate with the patient to build the bond, then we need to do that with the family as an extension of that patient. And they're finding that that does make a significant difference. And then a lot of time the personality traits of the family and of the patient and how they interact with each other and interact with us also plays a role in the outcomes for the patient. So we do need to think about the family if they're going to be involved in that patient's care and play a role in their life and then their outcomes. Is the cooperative therapist-patient relationship called the therapeutic alliance? Correct. That's the current terminology for the therapeutic alliance. It's been called many things. It's been called the working alliance, the cooperative relationship. It has many different names. For, most of us, it's instinct, right? But yes, therapeutic alliance is what we're talking about. If the patient-family dynamics are conflicted, which should we try to foster? It seems that choosing one or the other would affect outcomes. And it sounds like that could be the case. We can't fix the family dynamic. Yeah, the research doesn't say what to do. I guess the focus has to be on the patient and seeing what their goals are necessary. I'm sure we've all had those family interactions where we need them to leave. But if the family needs to be the caregiver, then we have to try and look at, different ways to kind of get in and target the relationship. Um, Again, maybe trying to get them to focus on the immediate goal at the time, or looking to see if there need to be other outside referrals. Sometimes the conflict may not be related to the fact that the patient, needs help ambulating or needs help in the shower. It may be related to the fact that, they can't pay their water bill. So maybe outside referrals are something to look at too. Sometimes I found, particularly with home evaluations, when we used to do those all the time and needing to make architectural changes, that a lot of times it wasn't about a family member coming home or needing to change the carpet. It was about other things that may need other referrals. Cognitive empathy is kind of more of a perspective taking, that you know what the person is feeling, you understand it mentally, but you don't actually feel it yourself. So I know my patients are in pain, and I know it is frustrating that, maybe they need a max assist to two people to get up out of bed because they're paralyzed on one side. I understand that. I can envision the struggles that they're having. That's cognitive. Affective empathy is someone who actually has that emotional reaction, that almost in tandem you're experiencing the same emotion that your patient is. You're having that physical empathy. If you're that person that you're watching a movie and you're, crying along with the character. And what the Big Five inventory does is it's utilized a lot in the research to look at different personality traits of individuals, and it helps identify different personalities, and then it helps show you when to use them. So it's a quick little self-assessment tool that can be utilized it's utilized, like I said, a lot in research to kind of look at the main domains of personality. And it's 44 questions. You just answer these little phrases, and then it tells you your personality style that you're bringing into the clinical environment. The main types of personality styles that are utilized on the Big Five are broken down to openness to experiences, conscientiousness, extroversion, agreeableness, and neuroticism. Some of the names aren't very flattering, but to talk a little bit about each one, really what we find is we need to use different pieces of this at different times. and sometimes we want to emphasize others and de-emphasize other ones. So someone who has openness to different experiences, this is an individual who has complex mental thinking. They're very imaginative. They're coming up with different types of treatment interventions, different ways to tackle different situations. Someone who is very conscientious, they demonstrate really good impulse control. They're going to be very task and goal oriented people, dependable, cautious, an achievement type of orientation. Someone who's an extrovert, right? Generally speaking, someone who's an extrovert, we think of they're very outgoing, they're very sociable, that they tend to have also, some of the times they have a little more of an emotional response, potentially more energetic. So that may fit better with certain patient populations. Individuals who have more agreeableness, these are looking at agreeableness is kind of looking at emotional stability. That someone who's a little more even tempered, that they're going to be flexible, trusting, forgiving, a lot of those traits that we think of in clinicians. And then neuroticism is going to be that person who tends to be a little more anxious. Maybe it tends to be someone who worries a little bit more, nervous, high-strung, temperamental, not necessarily the most effective traits when we have patients who may be exhibiting some of those traits.